Thank you very much for the opportunity to be part of such an elite group of clinicians and an excellent forum to share knowledge. I have been involved in neonatal practice both in the UK and in Canada, and I got interested in neonatal medical legal implications of practice um, when I graduated or when I finished my medical specialty training. I interestingly had a conversation with a senior colleague of mine who was retiring at the time. And he said to me, he said, Sumesh, there's a high likelihood that before you finish your career, you will be sued at some point. I was totally shocked by the comments, and because he was in his 60s at the time, just about to retire. And it actually scared me because I thought, oh boy, am I really that bad? Or was I really that bad a trainee that he has to say this? But he was sharing with me a change in the societal sort of expectations and the changes that have occurred over time in terms of expectations and what the repercussions could be with neonatal practice. And so I got interested in neonatology with regards to the law. And when I came to Canada, I actually did a certificate in medical law and started getting involved in providing medical expertise in this particular field. I have had colleagues who have asked me, well, why the hell do you do this? And the reality of it is that um, I have enriched my own clinical practice. I have enriched my own knowledge by participating in the provision of medical expertise. So with that as a background, again, I want to really thank Manoj and Professor Divakar and colleagues for this opportunity to share this presentation. It is a presentation which I do for fellows in our program. It actually is a half-day program. But what I'm going to do is quickly try to go through the key elements of this presentation. Before I get started, I want to sort of give a disclosure that I personally believe that there is a moral and ethical obligation for physicians to acknowledge medical error. I also believe that this is a mechanism for the advancement of medicine through risk reduction initiatives to minimize the potential for medical errors. As I alluded to, I do provide medical expertise for medical litigation cases, and so I have some vested interest and knowledge in this particular topic. The reality is medicine is a calling, medicine is a profession, medicine is also a business, and people in business get sued. And so, if you look at a snapshot of what is going on in the North American context, you can see about 61% of physicians who are over 55 years old have been sued. And in fact, 1 in 10 pediatricians are sued during their time in training. But here's the good news. The good news is that although there may be lots of litigation claims, the defendants, which is physicians like ourselves, prevail in more than 90% of actual trials. The vast majority of them actually do not go to court. If you're looking at the number that actually end up in front of a judge, it's about 1%. So when we look at medical litigation, there are two distinct elements there. There's civil litigation and criminal litigation. Now you look at the Indian context to this, is that to establish criminal liability, we have to prove that the course undertaken by the accused was in the knowledge that they would cause harm. And so therefore, they then become subject to criminal liability. The vast majority of claims are actually in the other two categories, where monetary compensation and potentially disciplinary actions are being sought. And these disciplinary actions are often sort of handled by our registration bodies, such as the General Medical Council in the UK, the Indian Medical Council in India, and here in Alberta, the CPSA. So, I think it's been increasingly recognized that, there is a need for physicians practicing medicine to be aware of how the judicial forum deals with claims associated with medical negligence, and that these claims have the dual purpose of protecting the public as well as physicians. And there's a key element here, and this is the element of minimum standard of care. Defining that for every case becomes the crux of the matter in decisions regarding liability. And the judicial law aims to strike a careful balance between the autonomy of doctors to make judgments and the rights of patients to be dealt with fairly. So the legal objective is to provide justice, a certain accountability, deter harmful behavior and future risks, and appropriate allocation of loss. The vast majority of litigations that come forward are civil litigations, and there are various sort of categories under which these fall. And these are, these were published in 2006, and these include diagnosis of error, obstetric errors, treatment errors, surgical errors, medication errors, and then there's a host of others. The legal claims for damages that result in neurological injury amount to the largest sort of awards for personal injury litigation. Physical and cognitive impairments may prevent working or functioning independently in the future, and therefore there's a significant amount of money that is apportioned for lifetime dependence and care provision. And that's how the numbers get into the millions of dollars when you look at the North American context. There are mega verdicts that have occurred across in North America. You can see one in the middle there, which is $144 million, which was awarded in 2011 in Michigan for negligence at birth. I'll come to how do we get to such large numbers. I mean, many of us are at this time aware that our personal liability insurance does not come anywhere close to this. And the way this happens is because what lawyers try to do is to rope in as many physicians into the negligence case, and if possible, rope in the institution. And that way you're able to reach numbers such as this. It is in reality a business, and we have to be clear that what is happening in the United States and in other parts of the world where litigious societies are increasingly becoming more and more perverse is that this is something that is likely to get worse, even in places where litigation at this time is not that much of an issue. So what makes babies different? The reality is that diagnosis in errors at the very start of life can result in permanent injuries, and the lifetime costs are staggering. The reality is when a child is injured, there's an enormous empathy from courts. Families go through periods of long hospital stay. The risks often include, the use of multiple medications, often packaged for adults. Many of you are aware that there are very few drugs in our patient population that have been studied to the extent that they've been studied in the adult population. Individualized dosages with the potential for errors in terms of associated with dosing errors as well as weight changes. And then the long statute of limitations. In other words, you essentially could be sued, certainly in our environment, until the child is about 21 years old. The reality is that most injury and impairment fall into categories which could have idiopathic causes, antenatal causes, and unpreventable causes. But what we are interested in are the potentially avoidable causes. That's where we have our liability. Birth-related injuries are a big piece of this particular issue. Many cases of CP are unavoidable, and we recognize that. Few are avoidable. I certainly believe that it is legitimate to ensure that liability is not imposed where it is unjustified based on best medical knowledge. In other words, it is unjust to sue a physician where the care provided was appropriate. In the same token, it is also unjust to deny compensation to injured infants and compensation to the families where applicable best standards of medical care were not implemented. So what are the litigation hotspots in this decade? We're looking at neonatal resuscitation claims, neonatal jaundice, therapeutic hypothermia for HIE, the preterm infants, and sudden neonatal unexpected perinatal collapse. So how do we tease through the pieces that establish liability? And it's looking at potentially avoidable causes and all other causes. And for this, what the courts apply is the Bolam principle. The Bolam test was established in 1957. It follows the decision of the court in which it concluded that a doctor may be able to avoid a claim for negligence if he can prove that other medical professionals would have acted in the same way. So in other words, for those of us who work in the in Western Canada, if you're a cowboy who basically shoots, as you wish, then the chances are that you may end up with problems. So compensation through litigation is based on a proof of balance of probability. The plaintiff has to prove that the injury was due to a potentially avoidable cause. The plaintiff also proves that the applicable standards of care were not met, and that intervention would have avoided some or all of the harm. Now, this is a key element because I think, I certainly have come across cases where multiple etiologies resulted in harm. And so if we can prove that one of those etiologies was potentially avoidable and could have minimized the degree of disability, then there is a claim. And the key to this exercise includes the use of differential diagnosis against all other neonatal neurological injury causes. And it relies on us understanding the timelines and the applicable standards of care at the time. In other words, if a case arose in 1992, we would be looking for expertise and guidelines and standards that existed in 1992, not 2020. And that's a key element for us to understand as to the importance of practicing within existing standards of care. So liability under the Consumer Protection Act, certainly from an Indian perspective, in 1995, the Supreme Court brought the medical profession within the ambit of a service as defined by the Consumer Protection Act. I am aware from colleagues, learned colleagues in India now in recent times, that this particular act is under review. But I think it's just important to recognize that, physicians are under the spotlight in terms of the potential for them to be called to defend their decisions. Now, it's important to remember that, when we talk about civil litigation and criminal litigation, when we talk about criminal litigation, it is beyond reasonable doubt. In other words, there is almost above a 90% certainty before you get a prosecution, which is different from medical litigation. Because what we need to prove is that there is a balance of probability which favors the possibility that the medical care provided was responsible for the injuries sustained. And in fact, the judge may draw an inference where a medical expert may not, based on common sense and a consideration of all circumstances. But it is the plaintiff's responsibility to prove the evidence of causation. So the standard of care, the plaintiff must prove on a balance of probability that the care provider failed to meet the appropriate levels of care in the circumstances. And as I said earlier on, standards of care are based on existing standards at the time of the care provision. So how do we look at standards of care? Based on a claim, Every practitioner must bring to his task a reasonable degree of skill and knowledge and must exercise a reasonable degree of care. He is bound to exercise that degree of care and skill which would be reasonably expected of a normal, prudent practitioner of the same experience and standing. Now, it is important to recognize that if you are a specialist, then the standard to which you are expected to function is at that of a level of a specialist. So if you claim specialty training, then the expected standards are that of a specialist. Whereas if you're not, then the standards are applied at a level that would expect a general practitioner to be able to deal with. So people like myself, what do? We put before the court material with reasons and that support our conclusions. Having said that, the court may form its own judgment using its own observation based on materials provided by the plaintiff and the defendant. So the experts the expectation is that we will render opinions that are intelligible, convincing, and tested. One of the key elements that I have found in my work with medical law is that I think it's always flawed if you take up a case with the aim or the bias to defend physicians or to prosecute physicians. It is important that we look at the case dispassionately and form an opinion after evaluating the standards of care provided. So this is a case that probably most of you practicing in India would be aware of, and this was a case that came out of Tamil Nadu, and it was based on a premature infant who was given supplemental oxygen and developed ROP, but was not referred for a pediatric ophthalmology review, and therefore was held to be an act of negligence. It is also important that, many of us sort of say, well, our hospital guidelines say we should do X, Y, Z. Well, those guidelines are useful if they are evidence-based and if they form standards of care. That we cannot hide behind guidelines and defend ourselves if an ordinary finder of fact finds that those guidelines were actually negligent practice. And it is important for us as administrators to ensure that the guidelines that are in place in our institution, because we protect physicians, we protect institutions by ensuring that the guidelines that are in place are contemporary and evidence-based as much as possible. So how do we reduce our risk? We have to document all care. If it wasn't documented, it wasn't done. We have to document conversations. We also need to make sure that we do not use the charts as a battleground. In other words, oh, Dr. So-and-so did not do so-and-so. That's not where it goes. And we have to document the chain of command. Now, this is particularly important in the North American context, where even residents and trainees of all cadre have got liability associated with clinical exposure. In other words, if they did not inform you of a deterioration or a concern, then the liability actually becomes more focused on the person where the chain of command was broken. So keeping informed about recent developments in the field is imperative. We have to incorporate current methods of diagnosis and treatment into practice, and the practice of evidence-based medicine is not optional. It is a moral, ethical, and legal responsibility of licensed practitioner. In other words, it is not optional, it is obligatory. The other element that becomes a topic where, an area where potential liability could arise is the area of confidentiality, ethics, and the law, where information is shared between people who do not really have the consent of the patient or the right to share such information. So what information is confidential? It really covers all identifiable patient information, whether it's written, computerized, visual, audio, or any form, and therefore it requires consent to be shared. So, this is just a little bit of entertainment showing how these sort of scenarios could play out. It's very important when we're using electronic communication to ensure that the information only goes to the person that it is intended to. Informed consent is more than just a signature on a form. It is an expectation to explain the nature and purpose of treatment, discuss the risks, the benefits, the alternatives, and to document informed refusal. Now, many of us will remember that, when the issue of steroids and treatment with dexamethasone was raised in the early 2000s, there was a lot of anxiety about its potential long-term consequences in patients, and therefore, certainly in the practices that I've been involved in, both in the UK and in Canada, we would get written consent. In other words, we would document a conversation with the family prior to starting dexamethasone. But we need to recognize that some of the evidence changes over time, and where there is dubiety about outcomes, it is always best to be very transparent in the conversations and to document this in the charts. Communication skills. I say that communication is very much an art as much as a science. Communication with patients, communication about the patient, and communication about the medicine and science that is being applied. To healthcare providers, communication is critical, but often neglected a component of pediatric and subspecialty training. And it becomes imperative, therefore, that we offer our trainees the opportunity to sit in with us and see how this information is packaged in a way that it is provided to the family as wholly and understandably as possible, but with empathy and consideration. We also have to be aware that there is an ethical obligation for us to inform families where errors have occurred. And in fact, there has been a program initiated in the United States where it's called Sorry Works program, where when errors have occurred and there's been harm, there is a conversation with the family very early on, and settlements can be discussed at a very early stage. So I'll give you a case of professionalism, because these are all realities of our day-to-day existence. So we have a corporate attorney who is admitted in labor. The obstetrician determines that the baby is in distress. The anesthesiologist is called, doesn't respond. An hour later, the anesthesiologist arrives, but in this time, the uterus is ruptured. The infant is born, severely brain damaged with limited use of arms and legs. So the question is, where was anesthesia? Well, in this particular case, he was upstairs in his call room with his girlfriend. So we have to ask ourselves the question, do you think the parents will sue? Do you think they should sue? So I think these are very pertinent questions for each one of us to reflect on. Now, resuscitation and respiratory care is one of the key pieces where litigation has always been sort of arising from. The hot spots are neonatal resuscitation, the actual resuscitation procedure, following NRP guidelines, intubation errors, failure to monitor, equipment malfunctioning, delays in diagnosis, and arising now is specifically the care of preterm infants. So resuscitation claims essentially fall within the listed categories here. Failure to have the appropriate personnel at delivery. In other words, you're expecting the delivery of a 27-weeker. It would be negligent not to ensure that we have the right personnel present to provide care as best as possible. Failure to appropriately ventilate the baby. Failure to give epinephrine by 3 minutes of age in the right dose and right route, failure to recognize and treat hypovolemia, failure to admit after resuscitation for ongoing care, failure to recognize and treat seizures, failure to resuscitate a baby, or failure to resuscitate resuscitating a patient against parental wishes. This is a gray area, certainly within the North American context, when we are looking at deliveries less than 25 weeks gestation. So resuscitation pitfalls. As I said, there are certain areas where we have to be particularly vigilant. We have to ensure that the patients who are resuscitated access the appropriate facilities thereafter, that we are vigilant for the outcomes that may suggest neurological injury, failure to recognize hypoglycemia, and other potential underlying problems. So the pearls of neonatal resuscitation are ventilation, 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 and ensuring that babies who are born in shock receive appropriate volume resuscitation. So the documentation of resuscitation is particularly important. We have to document our time of attendance at the resuscitation, resuscitation that was provided by others prior to your arrival, documentation of vital signs, not just quoting UPGAR scores, the time of onset of positive pressure ventilation, even if it was just bag and mask, time of intubation, on the ease of intubation, compression, cardiac compressions, and the use of drugs, confirmation of color changes of CO2 detectors if you're using one. Essentially documenting evidence of positive pressure, successful positive pressure ventilation, movement of the chest wall, auscultation of findings in response to IPPV. The timed sequence of changes in heart rate, spontaneous breathing, and color. And if you re-intubate, give a reason why this was done. So an example of this is an uncomplicated term infant where there was a delivery, thick meconium, the baby was born floppy, the RT did not intubate for 6 minutes. When they eventually did, it was an esophageal intubation, which was not detected for several minutes, and the patient ends up with a quadriplegic cerebral palsy. And the delivery nurse and RT are sued, and they have a settlement for $7.5 million. Failure to monitor. A full-term infant is brought to the neonatal unit. This is not uncommon if you think about it within our context. A patient comes in with a bit of respiratory distress, seems to be doing pretty well, is active, vigorous, and crying, seems to have responded to whatever we've done. We transfer back to the normal nursery, and then later this particular infant is apneic. The aide is told to take the baby straight to the NICU. Instead, she takes the baby to the nursing station. The infant sustains hypoxic injury and dies at 6 months of age. But you can see that the lawsuit here is for a $1.1 million settlement. Essentially, if a patient dies, then the settlement numbers are significantly lower because it is more compensation for the families as opposed to lifetime care costs. Monitoring equipment. A patient was born, the nurse did not take vital signs at the specified time. When she eventually goes to take the vital signs, the baby is not breathing. They call a code blue. Appropriate help does not arrive for 20 minutes. The patient is intubated, then becomes pink. The respiratory therapist uses a red ventilator tubing without an exhaust valve, and so you can imagine the lungs essentially get blown up. This patient ends up with cerebral palsy and severe permanent brain injury, and there is a successful litigation. So conditions where litigation is increasing are the times immediately after birth. So we think about a patient who was born at term, goes to the mother for a bonding period, and then is subsequently found to be gray, apneic, and bradycardic in the mother's arms. And if you actually imagine this, there's a limitation to what can be successfully achieved with visual inspection, intermittent visual inspection, while the baby is in the mother's arms. And this particular infant suffered an apneic episode and cardiac decompensation. A neonatologist is called, they successfully resuscitate the baby, but then the baby has developed CP. And the litigation claims inadequate monitoring during the bonding period. Now, for those of us who practice neonatology, we recognize that we're often having to balance risk versus benefit because the research on skin-to-skin care and rooming in has shown that it actually does have significant advantages to the newborn. But then, how do we manage that risk? We can manage that risk by having certain elements of caution built into our programs to minimize that potential deterioration while having skin to skin. Babies who have required positive pressure ventilation, low Apgar scores, severely acidotic patients, and preterm or late preterm babies. So again, it calls to question the standards of care that we all offer in our institutions. Who is responsible for the patient when the baby is on the mother's chest? These are gray areas that are constantly being debated. And so I don't have answers for you in all of them, but we certainly can have a discussion about them. So high risk situations for skin to skin, we've already discussed them. The positive pressure ventilation, low Apgar scores, late preterm, difficult deliveries, mothers who have received opiates or other material that could result in the baby being hypotonic, or a mother who is not capable of looking after a baby immediately postnatally, and other risk factors. Now, the big one, in fact, this is the one that forms 90% of the referrals that I get, and this is birth asphyxia. The reality is that it's not that uncommon. 2 to 3 per thousand. There's a 15 to 20% mortality, and 25% of the survivors have permanent clinical deficits. There are defining standards that have been established in terms of determining HIE, and we know that cerebral palsy as a consequence of HIE could be spastic quadriplegia or the dyskinetic cerebral palsy. It's important that before we attribute the disability to HIE, that we have excluded other identifiable etiologies. I had a case recently where, a patient had mild HIE, went home, was seen by a family physician at about 3 months of age, seems to be doing well, and then at 7 months of age started having seizures, and then had progressive neurological impairment. And the claim was based on the HIE, which obviously we dismissed because there appeared to be a progressive neurological disorder. And clearly that is the purpose of some of the expert opinions that we rely on. There are proxies for fetal hypoxemia, such as non-reassuring fetal heart rates, low scalp pHs, decreased fetal movement. These criteria themselves are not specific, but they could provide insights into intrapartum events. Sentinel events typically occur in the form of ruptured uteri, placental abruption, cord prolapse, amniotic fluid embolisms, and fetal exsanguination. And typically the injury is to the central brain structures. And it basically have a sudden and sustained deterioration in fetal heart rate, and the Apgar scores are 0 to 4 for longer than 5 minutes, early evidence of multi-system involvement, and early imaging evidence of acute cerebral abnormality. Partial prolonged asphyxia, slightly different. There is partial reduction in oxygen delivery. There's shunting of blood away from organs of less importance, and systemic injury precedes the brain damage. The primary site of injury in the brain is the parasagittal gray matter, resulting in spastic quadriplegia. You could also have a mixed pattern. Catastrophic events, such as a total disruption of blood supply to the fetus. There's no time for compensation. It's an all or none phenomenon. And the primary site of injury in this particular case is the basal ganglia. And typically, you end up with an athetoid type of cerebral palsy. So if you look at the monkey model, there's a sort of differentiation between the partial prolonged and the total asphyxia, and the patterns of changes that occur. So the litigation lawyers, the litigation experts are tasked with trying to look at these sort of scenarios in greater depth, trying to identify antepartum events that may explain the presentation postnatally and subsequently, evidence of maternal risk factors, fetal depression and encephalopathy in the immediate postnatal period, and breaking this down into antenatal and intrapartum, being antepartum, and then looking at resuscitation, transition, postnatal, and neonatal as the postpartum. I, as a neonatologist, I look at the whole picture, but my expertise is really called to question in reviewing the resuscitation, transition, postnatal, and neonatal care. Often for this kind of cases, they get an obstetrician or a fetal medicine expert to look at the antenatal and intrapartum care. Identifying patients who are at risk of hypoxic ischemic encephalopathy is the key element that is arising from litigations that are coming to us from neonatal birth asphyxia. Was the patient identified within the timeline where potential interventions that could mitigate long-term risk applied? And what makes this more tricky is because there is a timeline. Typically, the expectation is that we aim to achieve therapeutic hypothermia within the six-hour mark. There are risks associated with passive overcooling and or overheating. And the key element for those who work in regional centers is to ensure that referral to tertiary centers occurs as early as possible and that high-risk infants are identified as quickly as possible. Complete and repeated documentation of clinical evaluation and interventions in the management of high-risk babies becomes key to trying to defend or prove liability. The reality is, as I said earlier at the start of this, I do a half-day session for our fellows because, HIE and the law it's a separate topic in its own because there's so much minutia in terms of what we look for. Another emerging area is the care of the low birth weight infant. Now, this is not an atypical sort of scenario within our environment where, you're looking after a 25-weeker who is appropriately grown, and then, there is issues associated with neonatal care, and, the baby develops an intraventricular hemorrhage, postnatal acquired infection, goes home on oxygen, has obviously BPD, and the plaintiff claims that care was caused by poor neonatal care. These are very, very difficult cases to decipher because we have to go into the very minutia of care provided and try to establish whether the outcome has been exacerbated by care elements that were less than optimal during the neonatal period. One of the areas that we look at is, we know that, with prolonged ventilation, outcomes are worse. And that in itself is not an area where we can prove litigational liability. But, things like hypocarbia, where we have, patients who've been ventilated with prolonged periods of low CO2, we recognize that that is a risk factor for neurological injury. Similarly, prolonged periods of hypoxemia. One of the key elements that I always remind our trainees and colleagues about is how do we share information? Often some of us, because we're doing this and we sort of feel really good about the fact that we've had a very preterm infant survive, and we say, and the head ultrasound scan is normal. That enthusiastic sort of sharing of information is not in itself harmful, but I think what we need to be careful about is to express to the families and remind ourselves that the fact that you have a normal head ultrasound scan does not guarantee long-term neurodevelopmental outcome. We know that issues such as sepsis have specific risks associated with neurological injury. Increasingly, people are looking at missed opportunities and long-term outcomes. Why was antenatal steroids not administered at a reasonable time when the opportunity existed? Why was this mother not transferred to a high-risk perinatal facility when the opportunity did arise? Why was hypocarbia allowed to persist for a prolonged period of time? If there was a PICC line related risk, that in itself is recognized, but was it dealt with appropriately? Neonatal jaundice. The reality of it is that it is relatively easy to treat. It is often predictable. There are charts and guides to establish treatment thresholds. It's important to remember that these treatment guidelines do not give you guidance on when to discontinue. That is a clinical decision, because that clinical decision is based on risk profile. So therefore, the risk assessment for potential kernicterus requires clinicians to spend some time thinking about that. Why is this important even particularly at this time? Because now there are almost signature diagnoses associated with MRI. When you have staining of the basal ganglia, it is safe to say that this patient has suffered, bilirubin-related toxicity. Hypoglycemia, yet another emerging spot. Easy to treat. The problem with it is that we cannot define a single number that is universal or applies to every patient in the neonatal period. There are no evidence-based guidelines that define glucose levels or ranges that can cause or lead to irreversible brain injury. And there is no evidence that treating asymptomatic hypoglycemia improves neurological outcome. So what are the pearls in managing hypoglycemia? It's important that we document that we are trying to correct significant hypoglycemia. In our institution, we have fairly rigid guidelines. So say, for example, we identify hypoglycemia that requires a bolus of 2 mils per kg of dextrose. Within 30 minutes, that sugar has to be checked. Not 45 minutes, not an hour, but within half an hour. And that's a nursing responsibility. But you can see now that these guidelines, when they are in place, are helpful, because it also devolves the responsibility to other care providers. So why was the sugar not checked after half an hour? You can see this is how lawyers use that information to rope in other care providers and to tap into their professional liability. Inform parents what you're trying to do, explain the risks and difficulties and complications. Err on the side of a higher threshold if you have uncertainty about the ability to evaluate a baby with clinical signs of serious hypoglycemia. Put that in context. I mean, certainly since I've been doing litigation work, what I tend to do is if I have a baby who has got birth asphyxia or some sort of perinatal event which may explain the neurological status, but then I have a borderline or low sugar, I will treat it because I cannot be sure that that hypoglycemia is not the cause for the patient's condition. And as I said earlier on, it is important for us to establish and follow local guidelines for this sort of management. Plasma glucose concentrations in a neonate of any gestation or postnatal age should be greater than 2.8. Hi, there's somebody's mic unmuted. Most of the time. There is no evidence that transient values below this level are detrimental, but we should make sure that we don't allow them to recover or become persistent. When we have profoundly low sugars, it's important that these are treated immediately and that we treat any other serious signs of encephalopathy. So we should try to avoid risks that can result in hypoglycemia-related neurological injury. Again, why is this important? From a litigation standpoint, we now also know that there are MRIs that can be done to identify patterns of injury that tie in closely with hypoglycemic injury. So with that in mind, if you can see that, from a litigation lawyer's perspective, you just have to fill in the blanks. The nurse practitioner or neonatologist was negligent for delaying the treatment with sugar, thus allowing the baby, delaying the treatment of hypoglycemia, and therefore the baby goes into distress. You can basically put in all of these categories into there, and you see that there is a potential claim. So how do we mitigate risk? Guidelines and protocols, risk management and case reviews, practitioner certification and continuous professional development, simulation and testing, individual performance, team performance, and institutional performance. This is a key element to risk reduction, because the reality is that even our current neonatal resuscitation program has identified the importance of team function in high-risk situations. So having a simulation program minimizes your litigation profile and improves outcomes. So it becomes important for us to recognize the place and importance of some of these risk mitigation strategies. So the take-home message from my talk is, practicing evidence-based medicine is not optional. It is an obligation. We owe this to the population that we serve. So in the same way, it is an individual responsibility to maintain the skill and knowledge associated with the practice that you provide. Be professional, compassionate, and responsive. Document clear and complete notes. Communicate in a timely manner with families and your team. Get the team on board, especially when making difficult decisions. Collaborate with colleagues. If in doubt, get a second or more opinion. Why is that important? Because when we look at even the Boehm's principle that I talked about at the start of this talk, it says if another reasonable physician or your colleagues are likely to have done the same thing, then your liability is reduced, or at least you are not seen as somebody who willfully made a decision that was clearly wrong. And so just by discussing with colleagues, we are able, and I would suggest that, you know, as a means of strengthening that process, either speak to a senior colleague or speak to somebody who is at least had several years of experience like yourself, or somebody who is not afraid to share their opinion with you. Because if you ask your fellow the opinion, they may find it difficult to disagree with you. But nonetheless, it is so important for us to get into the habit of practicing collaboratively with our teams, because this is not a solo game. Neonatology is not a solo game. It's a team sport. And so we have to function as a cohesive team. And remember, if you get sued, it's part of the business of practicing medicine. You know, as I started off, told you that I was told that, you know, by my senior colleague at the time, that it is very likely that I will be sued before the end of my career. You know, touch wood, I'm still waiting for that to happen. But, you know, if it does happen, I am more aware of how the litigation process works, what are the expected standards that will be applied, and I have, over the years, incorporated mechanisms to minimize my own practice risk. On that note, I stop and open the floor for questions.
Well, thank you, Dr. Sumesh. It was interesting and informative, especially your comments about elements of how we can reduce our risks and as a team. We do have some questions that have come. One is a pretty interesting question which came, I think, from Dr. Anand Bharani. He is asked, regarding hypoglycemia, what are the legal implications of cortical blindness, because this can be picked up later? Which is quite a, I could say in the cricket terms, a googly.
Yeah, I mean, I think cortical blindness could be a feature of neurological injury to the occipital lobe of the brain. I think, you know, to be successfully able to litigate on such a claim, they would need to have an MRI and to identify episodes of hypoglycemia in the neonatal period.
Well, do you think that we should open up these avenues, because lawyers don't need more advice from us to go and track us down?
Well, I think, you know, that's a very interesting thing. But you know, if I had enough time, and as I said to you, I usually do this as a half-day session, I could give you a very interesting story about lawyers. You know, for those of you who have watched The Inglourious Bastards, you may remember the German soldier who went in to interrogate a family that was hiding Jewish people during the Second World War. Let us not underestimate the lawyers. These are highly intelligent, well motivated, And when I say motivated, we're talking millions of dollars of motivation. So, they read the literature, and it is negligent on our part to claim ignorance when the plaintiffs have the information. So, I think it is a very important, very interesting perspective. I think, it is better for us to be transparent and honest.
Yeah, I have a couple of questions before I hand it over to Lalan to complete the sessions. One is a rather interesting one. What would be the stance of the court if a tracheal perforation is done by a neonatal nurse practitioner? Can the neonatology be sued if the neonatal nurse practitioner is not an employee?
Well, the first question is, why would the neonatal nurse practitioner be doing the intubation if they're not an employee?
Because Dr. Talat Ahmad, he has asked this question. It's probably, yeah, please take over and complete the sentence.
Yeah, because I think the problem is, and this is where it becomes very, very fascinating. Because say, for example, if I was faced with that question, the first thing I would ask is, yeah, we do recognize that esophageal perforations are recognized, especially when we're using stylets, as part of a complication associated with the intubation. But then we would have to ask the question, what were the institutional guidelines in place, and was this person institutionally privileged to perform that task? And so this is like a gold mine for a litigation lawyer, because you now have the potential to rope in the institution. And there, the compensation is significantly higher than what you'd get out of a nurse practitioner or a neonatologist.
Okay, so I guess that is answered. This Dr. Tushar Kulkarni, he has put a pretty interesting question, which I think you did avert to during your initial presentation, saying that we should not make the case sheets a battleground. But he has asked a question: what about if a colleague misses a life-threatening event and we pick it up? Do we reveal it to the parents? Because now, if you don't reveal to the parents at that stage, then you are in trouble. And if you reveal it, your colleague may be in trouble. So it may not be written. Yeah.
Yeah, I think what would be wrong is to say, Dr. So-and-so missed the diagnosis of so-and-so. What you could write is, I have identified this particular problem. We have to be careful not to drop other people in the proverbial pit without, what we have a responsibility to do is to identify the problem, share the problem with the family. If the family then decides, based on the fact that they could ask legitimately, why was this not picked up? I'm not at liberty to discuss the management of other colleagues.
Okay, I think Lalan, you could take a couple of questions there while I jot down some of the questions that have just come in our Q&A box. Go ahead, Lalan.
Thank you. Thank you, Dr. Divakar. I must congratulate Dr. Sumesh for a very excellent presentation. So we have very important and practical question. How do you deal with an issue such as nasal injury because of CPAP? Who will be responsible, nurses or doctor or the hospital management?
Very good. That's a a very legitimate question. So this is where it becomes quite important for us to then look at. So in the North American context, we have respiratory therapists who have the responsibility of looking after respiratory equipment. Now, even in the UK, we don't have respiratory therapists. We have nurses and doctors. And I think it's a similar sort of scenario in India. So then the question is, who is primarily responsible for ensuring the interfaces are applied appropriately and for rotating the care, because we don't just leave those interfaces for several days or hours. These have to be managed. And so the questions that are going to be asked are, who is responsible? Is it the nurse? And this is determined by your institution. So this is where guidelines become particularly important, because the institution should have a guideline in terms of how often those should be checked. If there is a problem, who should be informed? If the information was passed on to the physician and nothing was done, then the physician becomes liable. Or as part of his assessment, he failed to pick up significant erosion to the to the airway. So it's a bit of a gray area in terms of how many people that you can legitimately rope into such a litigation claim.
Thank you. So another question asked by Archana Bilagi: who will be held responsible medico-legally if a nurse or a PG student makes an error in your absence?
Very good question. So the answer to that is it depends on where you're practicing. In North America, if the PG student did not discuss the case with me, the liability lies with that person. If they discussed with me and I gave them correct information, but they did not carry out the information, the instructions as I provided, and I have evidence to prove that, then I could. Ultimately, we need to remember that it is likely that we will all be named in the claim, and then through the process of discovery, which is a process which the lawyers go through, they start to eliminate characters from the plot. And then they are stuck with the main culprits. And so say, for example, in the United Kingdom, we had Crown indemnity. In other words, although we had personal liability coverage, the National Health Service had coverage which offered compensation for such claims irrespective of who provided it.
So, similar question asked by Dr. Subhash: who will be held responsible for IV extravasation of calcium or dopamine?
Again, very good questions. The question is, what was so here's the thing. Did it result in permanent injury? If it has resulted in permanent injury, then there is a potentially legitimate claim.
Yes.
If there is been a permanent injury associated with that, then the question is, who was responsible for that IV? Who placed the IV? Who was responsible for the maintenance of that IV? Was it the nurse? Because if it is the nurse, then the nurse should have been checking the IV site on a scheduled basis, which is determined by your institutional guidelines. And if it was not picked up, then that's a problem. But if it was picked up in a timely manner, and yet there was injury, then that's just part and parcel of neonatal intensive care.
Right.
Okay. Any other queries you have got? It's pretty. Some comments have come. How will you become an expert in medico-legal matters? And that's a very funny question, but I think it's interesting if you have got time to comment on that.
Yeah. So here's
Hopefully
the thing.
not by experiencing it.
Well, so that's why I shared my context with you in terms of when I started, I was terrified of medical legal implications of my practice, especially based on the fact that my colleague said something to me. And I actually had a colleague who was a medical expert. This is back in Europe. And what I did notice about that particular colleague's practice was that he was meticulous in terms of how things could be perceived and how he managed patients. One thing I would say is, think about medical legal work after you've had at least 5 years of clinical experience. Be aware of what the laws are. Like I said to you, I did a certificate in medical law. Most people don't need to do that. You just need to be aware of what is the legality, what are the legalities of medical practice within your country or your region. And then you might, I'm not sure how many of my colleagues online provide medical expertise, but typically what happens is that I have, say, over the last 10 years, I have introduced a couple of colleagues as expert witnesses. And therefore, the lawyers who contact me, I send them the cases because I really don't want to take on more than what I can deal with.
Oh, we've got one funny question, which I think is going to make all of us sweat. Who will be held responsible if an infant aspirates and dies during sleep in an NICU?
Well, if the patient aspirates and dies in an NICU, why was this patient being monitored? Was there a monitor on the baby? If the baby was not being monitored, why was it not being monitored? If it was when it went into distress, who was responsible for first response? But again, remember that these are all things that have the policies and guidelines in place, or should have policies and guidelines in place for every institution and every neonatal unit.
We have a question here from one of the very, very senior neonatologists of the country, Professor P.P. Maya. Honored to have you on board, sir. He said, how about employing doctors trained in legal aspects to deal with all these problems in the hospitals? Like, what do you comment on that? That you should.
Well, I think I'll put it, I can only give you a personal sort of perspective on this. You know, ever since I've been practicing, I've held administrative responsibilities. My knowledge of medical legal implications of practice has enforced my administrative roles in such a way that I am very aware and careful to ensure that we, as an institution, introduce guidelines, procedures, and practices that minimize risk. Risk mitigation is a culture. And for that to be effective, it has to have a team approach.
Okay, Lalan, over to you. I think there are a lot of questions coming up now. It's heating up.
So one question asked by Thomas John. How often has hypothermia on admission in an ICU been a reason for litigation? He's asking data.
Hypothermia.
Yeah.
I'm sorry, I don't have the information on how often it is litigated. We always have to look at these things from the perspective of, is hypoglycemia the culprit? Sorry, was it hypothermia or hypoglycemia?
Hypothermia.
Hypothermia.
About the hypothermia.
Yeah. So the question is, was hypoglycemia the key player in the long-term consequence that resulted in harm? So I think we need to remember that, you know, I can't give you an answer to that, except to say that, you know, if a patient comes to you hypothermic or ends up being hypothermic and then suffers consequences potentially along the lines of hypoglycemia, shock, or other mechanisms that could have resulted in neurological injury with associated disability in the long term, then yes, there is a case.
I think Dr. Thomas John has asked another question. I don't think, Lalan, you handled it. I hope you have not asked this earlier. A lot of advice is given by senior pediatricians over the telephone. How is a record of this telephonic advice created? Is it possible that if it is not recorded accurately by the junior colleague, will the senior pediatrician be at fault?
Absolutely. You know, this is why, as I said to you, this is why I am excited about medical legal work, is because we can think about all these scenarios, and yet we can also think about mechanisms to mitigate that risk. I'll give you an example. I'm the director of the Southern Alberta Neonatal Program. When I took over this program in 2014, I made sure that all our communication with referral centers are recorded. So we have a recorded phone line that we do not take phone calls on the side. We take them on the recorded phone call. Therefore, that phone advice is recorded, and it is actually stored as part of the medical record for that particular patient. So,
okay, I think that's great because there are too many questions. I'll just ask one more. It's, if blood is not available for exchange, then who will be liable?
Well, we have to ask ourselves the question. Is the center that is providing the care a designated center to be able to provide such care? You know, it's not reasonable for us to say we didn't have blood to provide a double exchange volume transfusion in a level 1 birthing unit. No one would be able to defend that. That's not an expectation. That's not standard of care. But certainly in a level 3 institution, if we do not have blood to be able to do a double volume exchange, then there is an institutional problem.
Would it be the institutional problem, or would it be the problem of the neonatologist?
No, it's not the problem of the neonatologist. The neonatologist needs to identify the need for it and put in the requisition for it.
Okay,
Where
Lalan,
the
over
blood
to you.
comes.
Okay,
Yeah.
so one last question. I think we are facing the COVID. So this is related to COVID and asked by Professor Saurabh Datta. In what ways will the COVID pandemic affect the medical legal aspect? If a newborn delivered to a COVID positive mom has to be isolated, but level of care in COVID isolation is lower than the main NICU.
Saurabh, I knew that you would ask some tricky question. So, I will give you a sort of generalized advice on this. So when the COVID issue arose here in Alberta, one of the points that I made to our group of practitioners was that we should have labels that we stick on the charts that say that this is occurring during a COVID pandemic. So therefore, standards of care are different as long as we recognize that this is occurring outside normal existing standards. So those are some of the steps that we can take to identify, because 10 years from today, unless somebody put a date stamp and wrote something about it, no one is going to know this happened during COVID.
I have a personal question somebody has asked you, Professor Leela Kamath. Who do you go for as an expert witness, as a plaintiff or for the defendant?
So one of the things that I have done, and I have done this ever since I've done medical legal work, is when a lawyer sends me a package, there is a covering letter which explains who they are defending. I don't read that. I go through the charts first. I go through the charts dispassionately, looking for standards of care. And there are many times I have told the lawyers, you don't have a case, or yes, you do have a case. And I think one of the downsides to it is, unfortunately, some medical experts could end up being biased because they are supporting physicians or prosecuting, physicians. So as expert witnesses, it is so important that we are dispassionate and completely unbiased in our opinions.
We do have too many questions here. I don't know whether we can go through all of them. One is an information which probably I'll give to Sumesh last before winding up. Before that, there's a question. If a diaphragmatic hernia is missed in antenatal scans and neonatologist resuscitates and the baby collapsed, who is responsible, radiologist or neonatologist?
Okay, so it depends on what your program is. So if you have a fetal medicine program and this patient had been seen and had serial ultrasounds, and that these defects were identifiable on the antenatal ultrasounds but not reported, then clearly there's going to be liability associated with that. If it was an undiagnosed diaphragmatic hernia and you managed it and the baby collapsed, then if you did not go through the standards of care in terms of recognizing that this is outside the norm, getting an X-ray in a timely fashion, on the first X-ray, recognizing that this is not looking normal and act appropriately, then you become liable. So that's how it works out.
We have not had many questions in hypothermia, so I'll bundle both of them together. One is, will a neonatologist be accused of negligence if a term baby born depressed at birth, but does not qualify for therapeutic hypothermia, but throws a seizure after 6 hours after birth and would qualify for cooling now? And I'll add the next question from another participant is, if a HI baby worsened during rewarming after 72 hours of cooling, what are the implications? I think this view, and finally I'll hand over to Lalan.
So therapeutic hypothermia is a hot topic in neonatology and in terms of litigation. The important thing here is that if a patient, by definition, and we have in our province certainly very clear guidelines in terms of what are the criteria, the history piece, the neurological examination piece. If a patient does not meet criteria, then the patient did not meet criteria, and that is medico-legally defendable, irrespective of whether the patient had a seizure thereafter. And
okay,
then
Lalan, go ahead, because there are 4 questions which on exchange, and then probably we'll just discuss with the organizers whether we have enough time for some more. Go ahead, Lalan.
It sounds like we should have a workshop on this particular topic.
Yeah, it looks like that. Looks like that. Lalan, go ahead.
So the question related to resuscitation. In an emergency delivery of an extreme preterm preemie, do we need to inform consent to resuscitate the newborn?
Well, it depends again on where you're practicing. I'll give you the context in the North American context. If a lady comes in with an estimated gestation of 25 weeks and above, we are expected to offer resuscitation, irrespective of parental views, unless there were severe adverse fetal risk factors which had been discussed and agreed to determine postnatal care. If it is less than 25 weeks, we do get consent. And if the parents are adamant about not going for neonatal resuscitative care, it has to be respected. So your local guidelines become critical.
So another question, in some instances, parents refuse exchange blood transfusion in religious ground for a baby, and the baby later develop kernicterus. What is your take on that?
So certainly I can answer this question from a neonatal perspective here in North America. The court will offer you guardianship and the decision-making capability to do the exchange transfusion if you believe that that intervention will protect life and preserve long-term function. The parents cannot refuse that for their child. They can refuse it for themselves and die as a consequence of it. But they cannot, at least in the North American context, and I know this applies even in the UK, is that if you believe that there is a serious risk to the patient's life, then you have the opportunity to pull in a court to rule in your favor.
We have a couple of questions here, if I could just butt in. Can I just, one of them again is on exchange transfusion. In some instances, this is from Veronica Ejika, if I hope I spelled it, pronounced it properly. In some instances, parents refuse exchange blood transfusion in religious grounds for babies, and the baby later develops kernicterus. What is your take on that?
That has already.
I thought I just answered that question.
Okay, sorry. The last one is baby born with cyanotic congenital heart disease like transposition of great arteries, not recognized antenatally, baby collapsed at birth. Is attended neonatologist liable? This is from Theo Tandar.
No, the neonatologist is not liable unless they fail to recognize that the congenital heart disease was part of the differential for the collapse. And if you recognize that the transposition is one of the potential causes for the collapse and you act appropriately, then you are fine. But if you didn't even think about it, and you have a baby who has collapsed with a potentially duct-dependent lesion, then that's negligent.
The corollary of the cooling has not been clarified. Dr. Uday Kumar has reminded me that he wants to clarify if a baby worsened during cooling after 72 hours of warming, what are the implications of rewarming?
So again, I think the key element that helps people to understand how the law is applied is understanding standard of care. So what is the standard of care? The standard of care is cooling for 72 hours. And thereafter we rewarm. So as long as, it doesn't matter what happens to the baby could be fine, the baby could deteriorate. Our liability lies in our application of standards of care. If we do not apply standards of care, then we become liable. Just similar to the patient that we discussed earlier on, where did not meet criteria based on the history and physical examination and characteristics, was not met criteria for hypothermia, but this patient ends up with neurological injury. We can defend that because it has been documented and clearly defined that this patient did not meet criteria for therapeutic hypothermia. Similarly, when we start to rewarm the baby as per the standards of care, whatever happens to that child in the future is defensible.
Lalan, we have got a couple of questions and go ahead.
Yeah. So Gokul Krishnan is asking very interesting question. Is it the
I've been told, Lalan, you're not loud enough. Could you come a bit closer? I got some messages saying
I think there is some.
Okay,
So-
that's fine.
So is it time that at least one doctor of an ICU treating team should have an exposure or certificate course in medical legal training, like NRP training we are doing?
Well, that's a very high standard to apply because I think even in the North American context, I think in a couple of weeks' time, I'm doing Trans-Canada rounds here in Canada on a similar topic. The reality is that this is not something that has as much, people are not as much aware as they should be. What I would say to you is that we all need to be aware because, there is individual risk and there's collective risk. I think it's always helpful if we are all aware and that we do some work in terms of enlightening ourselves as to how can we reduce our risk as an individual, as a team, and as an institution. Unfortunately, the reality is even institutional administrators do not know as much of this. And some of them don't really care because, it's a physician, he's going to get sued. It becomes their problem when the institution gets dragged in. And that's part of the reason why it's important for all of us to be aware of how we can serve our populations better and protect ourselves in the process by being aware.
Thank you. So another question, ventilator-associated pneumonia or sepsis, who will be responsible?
Ventilate, yeah. So again, the diagnosis, as long as the diagnosis was made in a reasonable time frame, you are not liable. The reason for that is because these are recognized complications of invasive ventilation. Just like, you put in a PICC line and it extravasates. That is a recognized complication of the PICC line. But if the PICC line was malpositioned and then developed a complication, then you are liable.
I think we are coming well beyond what the organizers have given us time for. And thank you,
Yeah.
Sumesh. It was extremely lively. And is there any comments you would like to make, Lalan, or can we just bid Sumesh, give him a good hand, though I'm sure at least we can hear you, it's audible to you. And as well done. And I think on the Independence Day of India, I've been really privileged and honored for being asked to co-host with my very close friend, Lalan Bharti, sitting in Delhi. Because with the COVID situation, I don't think I can fly that side in the near future and say hello to you also. So thank you very much. And I think I'll hand it back to our organizing team. Lalan, your last final comments so that we can hand it over to Manoj.
Thank you, Dr. Divakar. It was really an excellent discussion. And I would thanks Manoj and hand over this to Manoj and the organizing team.
Over to you, Manoj.
So thank you, Dr. Sumesh. As usual, your talks are fabulous. This is again another. There was a lot of apprehensions when we chose this topic because there are other topics which you could do better, people thought, but then you have proved us all wrong in that aspect. Now we come to the official vote of thanks. So may I request the Secretary of IAP Neonatology Chapter, Dr. Naveen Bajaj, to propose the vote of thanks.
Hello, Dr. Sumesh, and